So you can see here, there's the drug coating on top, the shellac paclitaxel, but you see there's nothing falling off. So this is a clear advantage that you don't lose the drug before you touch it with the gloves, or during the passage of the guiding sheet, or the long guiding catheter, or through the hemostatic valve. So it ends up there you want to have it. We have developed this kind of coating together with the University of Rostock in Germany, with the cell biological group. And basically, shellac is a natural product. So it's, I would call it a little bit in a funnier way, it's a shit of an insect. And this carrier lacquer is living in Thailand and is producing the insect on trees, and you scratch it away, you clean it industrially, and then it's used since ages in different industries. So in the past for turntables, for furniture polishing, but now used in the food industry. So that chocolate is not melting in your hand. So shellac hardens the surface. And also the Granny Smith apples are hardened on the surface of shellac. So that the customer, if he goes into the supermarket and sees the apple, thinks, oh, this is a nice apple. It's not brown, it's a very nice shiny one. And also the pharmaceutical industry is using this for tablet coating, makes them gastric resistant, and that it's not going to work in the stomach, so later on in the intestinal tract. And we use, an interesting thing for ladies, before I forget, is for hairspray, and also for nail coatings. There's shellac also nail coatings in there, so if they're painting the nails, there's shellac on your fingers. So you use it nearly by every day. The other thing is that shellac has got film-building properties, so it needs a swelling time. That's why you need to inflate the balloons for 2 minutes or longer. This is the raw component. If you get its contact with blood or fluid, you can see it swelling. So it keeps the drug in the vessel wall, and it's kind of protection from outside. So we have tested then this as a drug carrier in different tests, and we can say really that we have got no drug loss before the procedure. It's abrasion resistant, and we don't see any kind of washout effect. It's nearly nothing. And it was independently tested, and the principle is very, very simple. You take the nanoscopic paclitaxel particle, you mix them with the shellac, you bring it on the balloons. If it gets in contact with blood, the shellac begins to swell, and due to the inflation of the balloon, you press the shellac like through a sponge. You squeeze it out and press it into the vessel wall. So we call it a pressure-induced fast paclitaxel release into the wall. This is the principle behind it. So what is now the biggest challenge? The biggest challenges that you see after POPA, after stenting, it doesn't matter in the iliacs, in the SFA, or in the critical limb ischemia cases below the knee, high grades of restenosis. And the idea then was to start in the femoral popliteal arteries, because these are the most of the cases. Right now, I think we will see a huge development below the knee because of the massive increasing diabetic foot syndromes, massive increasing amputations, and increasement of diabetic patients. So, why all the companies have started in the SFA? It's pretty simple. The reason for this is that the SFA is the most trickiest vessel part. It's a very long vessel. It shortens, it's compressed, because you've got the muscle group above it in the adductor channel, Stents are extended there, there's flexion in this area, so it's a very tricky segment. And as you can see here, this is a straightened leg. But the hinge points are coming here. If the knee